Microexamination of urine, part 1. We're going to just cover the, start with the specimen preparation. So specimen requirements, best specimen is going to be a first morning, midstream, clean catch. Okay? First morning gives it time to concentrate in the bladder. Clean catch, obvious reasons. We don't want a lot of contamination. We want to know if there's actually, what's actually there. And then a midstream. So remember I talked about a midstream, you urinate some in the toilet and you're flushing out all the transient bacteria? Because we don't care about anything that's transient, just hanging out at the end of the urethra. We want to know what's actually in the urethra, in the bladder, in the kidneys that might be causing trouble. So it's a midstream. It's a better specimen because it's more concentrated, better chance of detecting smaller amounts of something that might be there because it's concentrated over the night. Has an acidic pH. Remember I said that bacterial infections aren't going to be real acidic, but the acidic pH helps these formed elements stay intact. As urine is more basic, if it is a UTI, and as they are more basic, it's a great way to start degrading your crystal formation and some of your cellular components. So in acidic urine, these stay more formed and they're a little bit better. Acidic urine, you're not going to get cell lysis. Cells don't, they'll hang out in acidic urine. In a basic urine, you're going to get cell lysis. Also, if you're in a dilute urine, you're also going to get more lysis. So we like the more concentrated urine and a little more acidity. Ideally, 25 to 50 cc's of urine. These urine cups that we have in the lab, the top mark is 120, so it's about 120 cc's. So we want somewhere, down in this. We don't need a full amount, we only need like this much. If you can't look at it right away, best way to hold on to it is in the refrigerator. Just make sure it comes to room temperature before you test it, because cold urines will inhibit some of these reactions. Any of these enzyme reactions on the dipstick, enzymes do not like cold most of the time, and so we want it to be room temperature so these enzymatic reactions can happen. Putting it in the fridge is going to stop bacterial or slow bacterial growth, but the problem with putting it in the fridge is you can get amorphous buildup of crystals. So it gets cloudy just by being in the fridge due to crystal formation. So sometimes when it sits too long, we have to deal with those amorphous crystals. Certain preservatives can be used for the sediment. I think I've got one actually. Urine specimen system with preservative. What is this preservative? I need more light. I'm old. You just see me at the restaurant the other night. It was hilarious. I had turned my flashlight on. I couldn't see. Contains 1 ml boric acid for urine only. Do not drink. No, it doesn't say that. It should. It probably should. So boric acid, for example, is this one. I don't know. Remember that chart I showed you on week 1? That chart of all of the different preservatives and like when you could use them and whatever. And I said don't memorize it. Your facility will have rules in place for preservation, because sometimes when you have to send the urine out, you will have to preserve it and put it into a special preservation tube. So follow what they say. If you have to, also if you're preserving it, you want to make sure to save a portion of the straight urine without the preservative in order to do a dipstick chemical result, because you can't do the chemical result on the preservative.
It says boric acid preserves protein and formed elements, alters pH.
So, okay, there you went back to that original chart.
Yep.
And that's why you have the availability of those charts. Do not memorize that chart. Do not memorize it. The idea is that you can look these things up. And that's one of those things that's not worth memorizing. Refrigeration is preservation of choice. That you do have to know. So what happens is we take the urine, we get a nice concentrated urine, right? And we're going to swirl it because remember all that sediment's gonna land in the bottom and we're gonna pour it off into one of these little tubes. This is a 12 mil conical tube and the 12 mils is up here. Now CLSI standard says 12 mils is what we want the volume to be because that's what the numbers kind of are based on when we evaluate it. So you take this, we put it in the centrifuge. Remember our centrifuges have 1, 2, and 3. This is 3. It's a slower centrifuge because we're not separating out plasma and cells and we want to hang on to those formed elements. If we spun it really hard, all those epithelial cells are going to go, we'll just be busted. We're not going to be seeing anything. So it's a nice gentle spin. It's a 5-minute spin, so it's a shorter spin than most of our other ones at 400 gravity. So like really, really mellow, okay? If you do not have a centrifuge that has it all figured out like we do, you're gonna have to use that nomogram, which you guys have done at some point, right? Did you guys ever do one of these where you like look at how much RPM and how fast and convert it? Did you guys ever do that anything? Okay. There's a special we used to make you do it BLS and we decided it was silly to make you do it then. But there's this nomogram. Anytime you get a new centrifuge, you have to measure from the center of the centrifuge to the end where the end of the tube. And then you follow it with, actually, is our next slide cover this? No. So you do this, you make a straight line then, and it tells you what the RPM is. Like I want 400 gravity, and my centrifuge has a 13 centimeter radius from the center to the edge. And so you line those two up and you follow it to where your RPMs should be. So it's pretty cool. I'll show you in lab, remind me. And I'll show you guys in lab when we start doing these, like how it's done, just so you understand. If you get a new centrifuge in, you don't want to just use the same times and speeds you did before. It's really important to always validate your new centrifuges and take care of that. When you get done, when it gets done spinning, the settlement will be down here in this little nipple area. What you do is you pop the top off. Oh, and by the way, patient name and medical record number on the side of the tube before you spin it because it's going out of your site. So full name, full medical record number. I also recommend that you guys put your initials on the top because several of you might be doing the same, most of you will be doing the same patients. So it's like, wait, is that one mine or yours? Who's this who? So put your initials on the top so when you go to the centrifuge, you know which one you put in. You pop the top, you hold it over a dirty sink, and it's where you have to trust. You dump it, you hold it, and you flip it over. You do not do one of these, oh man, because what happens is there's a surface tension here. So when you dump it upside down, let everything drain out, don't shake it, because that'll bust your surface tension and you'll lose your button. So you dump it, let it drain, you flip it up. Then you take your finger and you just flick it, put a pipette in, up and down a couple times. There'll only be a little bit in the bottom, but that gives you the right concentration to do the reporting out of your urines. Then just put the lid on these and hang on to them in case we need to go back to them till the end of class. So always just hang on to these on your counter because there will be times you will have to come back to them. You're gonna take your pipette, pull up a little bit, and we got these little slides. Way back when we put a drop and put a cover slip on, these instead are calibrated. I'm gonna pass it around after I throw it on the floor. And you'll feel the wells. It's actually a little well. And you'll put your pipette on the little corner and it'll fill the well and you'll look at it through here. We do one at a time, especially as you're starting because they evaporate. As they evaporate, what might have been 20 red cells in each field, as they evaporate, there's more and more per field because they're shrinking down. So we'll let you look at that, pass it around. Each urine gets its own dedicated pipette. Remember, every time you enter sample, any patient, anything, it gets a dedicated pipette for that sample. Because if this one has a lot of white cells and this one doesn't, and I use the white cell one first, I'm putting white cells into the new one. So you always use a dedicated pipette for each sample. When you're squeezing it, you barely squeeze it because the capillary action is going to suck it in. So you're not like filling it. You're not squeezing it hard and filling it. You're just squeezing it enough to put a little drop at the tip and the capillary action will pull it in. There are stains available for urines. We do supervital stains. The Sternheimer-Mablin is one. It's most common. It's going to enhance the material on the inside. So it stains like the cells. So it stains actual like living cells. Acetic acid we use, it's not really a stain, but what it does is it takes the nuclear pattern and helps the nuclear pattern of the white cells and epithelial cells kind of like show up better. We also use it when we differentiate yeast. We can put it in, like we can't tell if we're looking at red cells or yeast. You put the acetic acid in, and it's going to lysol your red cells, and all that's left will be yeast. Fat stains sometimes get used, Sudan3 and oil red O. They're going to stain our neutral fats, such as our triglycerides. We don't do these real often. We don't see fats very often, and we'll talk about when we see fats in a little bit later of the lecture. But we sometimes see these in free-floating and droplets or globules, and they're called oval fat bodies. Or sometimes it'll stain inside of a matrix of a cast. So if we stain it and they suck it up, we know it's fat. Gram stains, sometimes we gram stain our urines. Gram staining urine is kind of tricky though because there's so few bacteria and things in it because we're primarily looking for bacteria. So a lot of times what they might do is put a droplet, a dry, put a droplet, a dry, put a droplet, a dry, and stack it because there's just not enough bacteria in a normal drop of urine to see much usually in a gram stain. And then the last stain we sometimes do is the Prussian blue stain for HEMOSIDERIN. When we're looking for HEMOSIDERIN in urine, the Prussian blue will help us. When we're looking at microscopy, bright field microscopy, we see structures with a refractive index similar to urine. They're going to be really hard to see. So in those situations, we're going to use phase. We will go through all these together when we start. April 11th actually is the first day we're using microscopes in the lab. You've all gotten used to using microscopes now in hematology, but now we're looking at unstained things. So it adds a layer of complexity to it. So usually when you're looking at something stained, you have that condenser all the way up. When you're looking at something unstained, these things are hardly there. You're looking for refractalness more than anything. So you're going to drop that condenser down, and it's going to help us see the outline of what we're looking for. And then when we go to phase, it helps things grow, or glow. So here is bright field. Here you can see is phase, bright field, phase. You can just see here, you can actually see the outline of this. So it's like I can be looking at this going, oh, is that just a clump of something in the mucous membrane? And then here I see, oh, nope, here's the outer line of it, so I can actually see it's a cast. So phase helps us really look at things a lot more carefully. However, some places don't have phase microscopy in their lab, so we make you learn how to use light microscopy and how to set your microscopes for yourselves to help you better see what you're looking at. Polarizing microscopy, when we do this, it's just going to detect the presence of cholesterol. Again, we don't see fats in urine very often, and a lot of places don't have polarizing microscopy in their labs. We don't have it here. There's nothing we can really do to see it. It helps you to see certain crystals, and you can see here starch powder crystals using polarized microscopy versus bright fields. You can see you get this nice Maltese cross. When you're performing a microscopic on a urine, I'm just trying to decide how far to go with you guys today. I'm trying to think it through, what's a good stopping point. You're going to put the slide on the stage. You're going to look at it on 10x first, right? That's how you look at your everything. Start on your 10x. Adjust the microscope. You're going to adjust it. You're going to drop that substage down. You're going to lower your light down to medium. You don't want a lot of light. If you have too much light, you're not going to see anything. Then you're going to scan the microscope using that 10x objective, and you need to look at about 10 fields. You're looking for casts and squamous epis. And we'll talk about what those are coming up. So those are the two things we look at under 10x. And when we're looking at a field, what that means is, let's say, so you guys saw how it had that half loop. When you're looking at 10x, the microscope, when I'm focusing, I'm looking there. That's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So I'm going to scan 10 fields. After 10 fields, if I don't see anything, they're not there. I'm not going to keep looking until I see them. Too many students spend 20 minutes scanning on 10x. Like, no, these 10 fields should take you about 3 minutes. Unless there's a lot to differentiate between, in which case it might take 5. Then we're going to move to the 40x. So what you do is you put something in the middle of your 10x field. Put some structure. So when you move to your 40x, you have something to make sure you can focus on right away. Especially if you're looking at urines that don't have a lot in them, you want to make sure there's something in the middle of your field. When you flip to the 40x, you should only have to adjust your fine focus a little bit, just to bring you into focus. It should be there. If not, there's either a problem with the microscope, usually it's other problem along the way. You were focused on the wrong field, something like that. Because one of the problems when you're focusing, if I'm looking at the slide like this, the well is like that, and so I have people that focus on the cover slip. They see a little mark. When they're looking in the scope, they see this. They're looking in the scope and they see this mark. Well, it's a mark on the cover slip, and that's what they focus on. You've got to focus here in the middle. Okay? And when you're scanning, you're constantly playing with that fine focus because you've got to constantly be going up and down, because if there is something up here, you may not see it if you focus down there. So you want to be able to go up and down with that fine focus the whole time you're doing it. So we flip to 40. We're going to adjust the focus and we're going to adjust the light. When you hit 40x, you may need a little bit of more light than you did at 10x to make it look right. So you're going to adjust the light till it's good for you. Now, don't forget, you've already adjusted the scope so that your oculars are set at the right spot where you're looking at one circle and it's sitting at the very edge of your counter, so you're sitting on your chair. You should be able to look right in without bending over or leaning over or doing too much stress. You should be sitting, it should be right there. So then, what we're going to look at 40x is renal epithelial and transitional epithelials, red cells, white cells, bacteria, yeast, mycelia, crystals, fat, trichomonas, and other miscellaneous. Now, do I go through each field? Do I see any of those? Do I see any of them? No. You go into a field, what do I see? You're going to mark it. Go to another field, what do I see? You're going to mark it. You're going to look at 10 fields again. Now this time though, your fields are going to be a lot smaller because now you're at 40x. And I always say move that scope around, to get all around. There's 10. So move it around. Make sure you're getting like a representation of what you're actually looking at in that whole thing. You look at 10 fields, you're done. You didn't see anything, it's not there. Do not just keep looking. You do not want to sit and be looking at one microscope for 45 minutes, looking for something, okay? A lot of these times, the main things we're going to see, squamous epithelials on our 10x, because that's going to be the epithelial cells that we see just from skin. And we're going to see, most of the time, red cells, white cells, and bacteria. Primarily, those are the things you're going to see most of the time. Normal urine sediment, red cells 0 to 2, white cells 0 to 5, hyaline cast 0 to 2. We'll talk about these later, what they all are. And then these guys we see few of, and there should not be any abnormal crystals or bacteria. Although, remember how many hands it takes for a clean catch for a woman? We can almost always find bacteria on almost every urine. That is where I'm stopping this lecture. So red blood cells, anytime you see greater than 2 red blood cells per high power field. Now first off, high power field. What does high power field mean?
40x.
40x. We do not look at urines under oil. We look at urines under 10x and 40x. Now if you remember, right now when you look at your 40x objective, when you guys are in heme, it's got the finger cod on it, right? How many times have you accidentally run that through the oil? This is why we have the finger cod on it, to protect the actual objective. So when you're in urines, you'll take the finger cod off, and as soon as you're done, you'll put it back on. Because we have found out that it actually saves our microscopes. The people that come in to do annual cleaning, the first time the guy did this, he kind of laughed at us. And when he was done, he's like, I'm telling every school to do this, because it was so different for him to clean, and it saved the wear on the 40x. So when we're talking high power field, we are talking 40x dry. We can't use oil or 100x because we're looking at a thickness and it's not stained, so it's just not gonna work. So anytime we see the greater than 2 red cells per high power field, it's significant. It means something's going on. We shouldn't really see red cells. So if we see greater than 2 per field, it's definitely a problem. Now you might see 1 or 2 on the whole slide. That just might be a contamination or something else going on. But greater than 2 per high power field is significant. At this point, we're looking at some sort of bleeding at some point in the urinary tract system, somewhere from the glomerulus to the urethra. Something is actually bleeding if we're having real red cells in the urine. Causes of hematuria, glomerular membrane damage. The sieve gets big enough, the red cells are coming through. There's a great reading about dysmorphic red cells in this unit of module. Take time to read it, look at the pictures, and you can see these dysmorphic red cells. And the bigger the holes, the less dysmorphic those red cells are going to be because they're not squeezing through. Vascular injury within the urinary tract infection, so any sort of injury within the nephron. Infections, tumors or lesions are going to cause some bleeding. Stone formation, when we get to stones in a little bit here, you're going to see as the stones go through, they can just like cut the heck out of these nephrons. It's miserable. And then strenuous exercise can actually cause bleeding into the urine also. When hematuria is noted in a female patient, the possibility of menstrual contamination must be considered. One of your patients yesterday was a 30-something-year-old woman with small amount of blood. It was menstrual contamination is what we were trying to get at. So just, I didn't mark off. I wasn't pushing that. At this point, you guys aren't ready to like really put the pieces together, but I do know 1 or 2 of you actually brought it up. That's awesome. You're thinking the deeper. That's what we're looking for. So red blood cells are smooth, biconcave, non-nucleated discs between 6 to 8 microns in diameter. Oops. We're going to kind of keep a list going here. 6 to 8 microns in diameter. Crenated, these are some crenated cells. They have spicules on the outside. So remember when they crenate, it's kind of like that ball, that play ball that's been in the backyard all winter, and it kind of shrinks down. The outer cell wall becomes crenated, and it looks like little spots all over the red cells. These are what we're going to see most of this time, and you can see the little spots in the middle. When you go up and down with your fine focus, those little dark spots get bigger and smaller because remember, you're looking down on something that has a divot in the middle of it. This one, they're all pretty flat. Sometimes they'll be on their sides, things like that. Like here's one, you can see this one's on its side a little bit more. So remember, they're in fluid. The little red cell's in fluid, and so it can spin around and do different things and be at different angles. So here are some normal red blood cells. These are called ghost cells. When you're dealing with a hypotonic urine with a specific gravity of less than 1.010, a lot of times these cells, the big water balloons, right? They're going to fill up and they're going to burst. So when they do, they lyse, and you end up just noting the cell membrane because the hemoglobin and all that stuff is going to lyse out and spill out. So they become these ghost cells. It's very, very important to make sure your light is set right, your condenser is down, your light is low, or you will not see these because they are not very dense. There's not much to them. It's just a cell membrane. And then here in a hypertonic urine, you got the crenated red cells, so that's kind of what they're going to look like. Here's some non-crenated versus the crenated cells. They look like they're cells with inclusions. It's not. It's just the cell membrane scritching down. Scritching, that's the technical term.
Scrunching and squishing.
Scritching, yeah. Dysmorphic red cells, what I talked about, they are a significant finding because what they're telling us is that there is glomerular disease, glomerular damage, and they're squeezing through the glomerulus and they become dysmorphic. Dysmorphic, unshapen, right? They're abnormally shaped, dysabnormal morphic shape. So what happens is they squeeze through and you can see they get these weird like shapes to them. The black ones here are the weird shapes. The blue, these are white cells, the blue, so you can see the difference in shape of size. Here's a normal one, but here's like these abnormal shapes. That's what we're looking for. Oftentimes, red cells can be confused with lymphocytes. Those don't look like lymphocytes. Those look like, oh, here. I'm trying to see where the lymphocyte is here. Maybe they're talking, these guys, I guess, are maybe talking about being the lymphocytes. These look like granular sites. Here's your red cell. So they're pretty close in shape. The nucleus is going to have more of a textured appearance. What does it mean when we have lymphocytes in a urine?
UTI.
Not lymphocytes.
Bacterial infection.
No. Lymphocytes. Not granular sites.
Rejection of a spleen transplant.
Kidney transplant.
Kidney
Good.
transplant.
Yes, you got there. Yep. When we're looking at the neutrophils, you're looking at an infection. When you're looking at the lymphocytes, if you've seen lymphocytes, it's really indicative that there's some sort of a kidney rejection happening at that time. So here are your calcium oxalate crystals. We'll be talking a lot about different crystals coming up. And what happens is when they're really, really small, they kind of look like a red cell because they build. Crystals grow and build, and when they do that, this is what we're kind of looking at when they're fully grown, but when they're small, they're like this. And if you look at this, you can see how refractile that is and how much smaller it is, but it does get confusing sometimes when you're looking at these live. If you're seeing a lot of calcium oxalate crystals, anything you're looking at that's small that looks like a red cell, look at it a little more closely. Bubbles and oil droplets can sometimes look like red cells. The big thing here is you're looking at the difference in sizes. Like red cells tend to be, if we go back a slide, I'll go back a couple slides, pretty uniform in size when you're looking at them. If you're looking at bubbles, you can see we've got lots of different sizes, and oil droplets, lots of different sizes. So that's one way in particular you're going to find out.
The lymphocytes also show with blood transfusions also, is that true?
I'm not sure.
If it's not doing well, there's agglutination and stuff.
Agglutination.
Right, with blood transfusions.
Okay, we don't get agglutination in the body. Agglutination is an in vitro, not an in vivo.
Okay,
There's hemolysis in vivo.
okay.
I'm not sure about the lymphocytes in the urine with transfusions. I've never heard of that. I could look into it some more and get back to you on it. Yeast. You can see these are my yeast. This is my ghost cell. Here's my little red cell there. So you can see they're kind of a little bit smaller, a little more ovate. They have a thicker wall. They also show more size variation. Here's some yeast with budding forms. That's the main way we're going to be able to see if it's yeast. There's going to be some budding on the screen. Here's a pseudohyphae, it's called. They call it a pseudohyphae because a hyphae you get with fungus. With yeast, it becomes a pseudohyphae. It's not a true hyphae. It's a pseudo fake hyphae. When you are looking for yeast, if you're trying to differentiate, if you're looking at yeast or you're looking at a red cell, look for the budding, look for the pseudohyphae. One thing we can do, I thought I had one more slide on this, to differentiate between the yeast and the red cells, if you're looking and you can't tell, you can do a count. And then you can add a drop of acetic acid to a drop of urine, put it on the slide, and what's left will be the yeast. And then you can do a count of the yeast and kind of do some calculations to figure out what you're looking at. White blood cells. Anytime we see greater than 5 white cells per high power field, it's significant. Most common one we're going to see is segmented neutrophils. They may enter the urinary system because of trauma or injury or infection. It could be either way what's going on with these. They're capable of migrating. Remember the video we talked about with the diapedesis, with the white cells that get into the urinary system? That's what we're looking at here. They can migrate in if there's an infection in the system. Anytime we see an increase in white cells, we call it pyuria. Py means fire in Latin, and white cells, infection, pyuria. When you look at Streptococcus pyogenes is your group A strep that causes strep throat, and your throat is on fire because it's lysing the red cells, it's destroying it. So that's where you kind of remember the pie.
Isn't it pus as well?
Yeah, so the fire, and yes, there is something with that, but pyro is fire, and so it's actually in Latin, it's more fire.
Okay.
But it does, in English, we look at it as pus also, but in Latin itself, it's the word root, I hate that word, word root for fire, pyro, Okay, think pyro, anytime you see that fire. And this fire infection causes us to feel like things are on fire. Look at that. So white cells, the neutrophils are at the black area, arrows here, and here are your red cells under the red area arrows. You can see they're more granulated, but even like this one, these are spicules, so you can see how easy it would be to mix them up, except for the size. The size of the white cells are gonna be bigger. Here's large sheets of neutrophils. This is a really close-up. Unfortunately, we don't have any scopes that'll give us this look, but of the lobe nucleuses. So when you're looking at them from like this far up, you see what looks like more the granules in the middle, but it's actually the nucleuses. We just can't get close enough to actually see what's going on in the middle. Here's a neutrophil versus a squamous epithelial cell. I'll be talking about squamous epithelial cells coming up and how we differentiate them, but you can kind of see the difference in sizes there. Hypotonic urine, same thing, they're gonna blow up and get really big. Well, when they do that, they become what we call glitter cells, because what happens is their granules have this Brownian movement, meaning they just kind of like flutter, so when you're looking at them, they sparkle. So that's what we're looking at with them. They're called glitter cells, they're swollen. Hypertonic units, neutrophils may shrink. When they do shrink down, sometimes they're gonna look more like a created red cell, so it is harder to differentiate those. Other white cells, eosinophils, drug-induced interstitial nephritis, lymphocytes, renal transplant rejection. Talked about that a couple of times now. Lymphocytes do not contain leukocyte esterase, so we will not get them on the screening test. You dip the urine, it's not going to show up because they don't have leukocyte esterase. So because of that, you could have a negative dipstick for for leukocytes, and something else triggered that you need to run a microscopic, and you might see them on microscopic. Especially in this area, we do a lot of kidney transplants in this area. Other white cells, we got monocytes and macrophages. We may see them in urosediment with infections and other inflammatory conditions. We don't see them much. They may be there, but it's going to be one of those things that you're rarely going to see. The neutrophils usually do a fairly good job of taking care of infections. Bacteria. Urine should be sterile, okay? Think about it. It's the glomerular filtrate is plasma. As it's going through the system, there should be no bacteria in your system, so it should be sterile. So we usually aren't going to see bacteria in urine except for contamination. And the only times we see it are contamination or an actual infection. Most of the times, urine is going to have a couple bacteria in it, just because, remember the 5-handed technique from women's midstream clean catch? So there's going to be a handful of bacteria. Bacteria double every 20 minutes, and because of that, that's when we could potentially start seeing bacteria on it with contamination, and the urine is allowed to sit out at room temperature for too long before it gets to us. Many labs are going to report out bacteria in freshly voided urine when you have the white cells, particularly neutrophils. This is going to indicate a urinary tract infection most often, and is going to reflex to a urine culture in most places, especially if they know it really was a clean catch. So bacteria, this is what the stained ones look like. Here's what they look like unstained. And these are rods. Rods are definitely easier to see than cocci. Bacteria is the one thing that you have to stop and say, do I see bacteria? Because what happens is, I told you, you go from field to field, what do I see? What do I see? The problem is the bacteria are so small and so in the background, you kind of have to adjust the focus of your eyes a little bit, to look beyond the larger cells. Do I see bacteria in the background? Thankfully, the cocci have this Brownian movement, so it kind of jiggles around. It's seriously like a pencil dot in the middle of your field, jiggling around. I always joke, we have music up loud and it likes to dance, so hopefully it helps it dance for you to see. They don't. Actually, I had a teacher one time tell me, students are going to believe you. No, they're not. But just in case, do not believe me when I tell you that they're dancing to the music, okay? Epithelial cells. We've got 3 types of epithelial cells, squamous, transitional, and renal tubular. The squamous cells are going to originate from the lining of the vaginal and the lower portions of the urethra. They're normal. Our skin is constantly shedding cells, right? These are the normal ones we see. This is why what we try to do is catch that midstream. So we flush out anything that's loose so the cells we get will be real. Transitional cells originate from the lining of the renal pelvis, the bladder, and the upper urethra. And then the renal tubular cells are actually from the proximal to the distal convoluted tubules into the collecting ducts. So the farther up we have these cells, the more serious we're looking at. The morphology of the renal tubular cells, though, is going to vary slightly depending on where exactly they're found. I'm going to tell you right now, in our lab, as long as you recognize one of these from this, you're going to be okay. Because the transitional and the renal tubulars, we're not expecting to see as many of them. I want you to recognize them. We will talk about them. I will help you with differentiation. But because our urines are a little older, sometimes it's a little harder to differentiate between them. So I will never bust somebody for calling them one or the other, except squamous. Squamous are obvious. So squamous, like I said, we're going to see them the most often, but they are the least important, least significant. A few squamous cells are common. Like I said, it's just their contamination. It's going to happen. Increased numbers, oftentimes we see with larger amounts of contamination when we're dealing with foreskin issues, vaginal secretions, things like that. When we see a lot of squamous epis, it usually tells us it was a poorly collected specimen. So if we do get a lot of bacteria, but there's a lot of squamous, we probably won't send it off for a reflex to culture because garbage in, garbage out, right? So we want to know what's really there and what's really causing the problem. We don't want to know what is, just hanging out because we're going to get transient bacteria. So squamous epis are large. They're 30 to 50. Microns. They're huge. Well, in comparison. Everything here is microscopic, but they're huge in comparison. They're irregular cytoplasm. They have a central nucleus about the size of a red cell. So sometimes it looks like, oh, there's a red cell. Nope, it's a central nucleus. They're flat cells, and we call them squamous, and I'll show you on the next slide because there's like one corner that looks like half of a square. And sometimes they could be curled up. So we'll talk about these coming up. So here, see how I have this side that looks like a square, but then this like jagged in? That's a squamous epi. Squamous meaning square. Here's some red blood cells, and you can see the size of the nucleus is about the size of a red blood cell. Here's a couple more squamous epis in this guy, and you can always tell, like this guy here doesn't quite have it because it's kind of folded over, but you can see the flat edge right there. Here you got a flat edge here. You can see this whole edge is kind of rolled over a little bit. A clue cell, when you got epithelial cell of vaginal origin, and they have a lot of bacteria hanging on to it, so you can see a lot of bacteria here. Here's a lot of bacteria hanging on to it. Oftentimes we see these with bacterial vaginosis. And bacterial vaginosis is an infection with this Gardnerella species. These are sheets, so you can see how many you have there. You kind of have to estimate when you're looking at them by looking at how many nucleuses you see. So I see 1, 2, 3, 4-ish right there. Looking at this guy, 1, 2, 3, 4, 5, 6, 7, 8-ish, 9-ish maybe, 8 or 9. So you have to count. When you're counting these, you're going to do estimates. We're going to go over this in lab tomorrow when we're counting these. Urine counts are estimates. I do not expect you to literally sit and count every cell on every field because you get ranges. Are there, 0 to 2, 3 to 10? I don't remember exactly what all the ranges are, but 10 to 20, 20 to 50, greater than 50. So there's ranges. I want you to do quick estimates, and we'll talk about how we're going to do those tomorrow. One other thing I want to talk about, I don't have a good picture of it, but see how these edges roll? Sometimes the edges of these flat cells are going to roll all the way up. I call them taco epis. That's not the original, that's not the formal term, but the problem is I want you to think about them as you're counting them. When they're all rolled over on each other, that is still an epithelial cell. And a lot of times, especially with our urines as they get old, the cells kind of like fold in on each other. And imagine like a tortilla shell, which is what these look like, rolled all up, right? So we call them taco epis, just to remind you that you do count them as epis. Transitional epithelial cells, 20 to 30 microns. So they're small binucleated, so it's more of a round, it's a rounder cell though, it's not, doesn't have the square piece like our squamous. Round or polygonal, but pretty much when we see them, they're gonna be round. Once in a while, you will see these that are pear-shaped and they have a little tail, and those are called caudate cells. They're very, very specific for transitional epithelial cells. They're able to take up water, so sometimes they end up getting like real spherical, like a water balloon, especially in hypotonic urine. Very seldom are these actually pathogenic unless they're present in large, large numbers and they have abnormal morphology. Because remember, these are like from the ureters and bladder down, they're not actually from the kidney. They're transitional. Here are some pictures. They're nice and round. Here's your squamous epi in comparison. Nice and round with a nice central nucleus. This is a caudate form. It's got this little tail. Here's one with a tail. Here's some that are stained. Here's a close-up. So nice round circle with a nice central nucleus. That's what we're looking at when we're looking at these cells. Here's a transitional epi. Here are some white cells. So you can see they're close in size, but they are bigger. So now renal tubular cells, these are going to be the most clinically significant. They are going to be, size and shape are going to vary. I'm going to get to the next slide for size and shape. They're going to originate from the convoluted tubules and the collecting ducts. So depending on where they originate will be the size of them. Anything more than 15 per 10 fields, that's like 1.5 per field, is evidence of actual renal injury or disease going on. So when you see these in more than 1 per field, you need to be paying attention because something's going on with this patient. So here is some from the proximal convoluted tubules. 20 to 60 microns. Granular cytoplasm, nucleus, because they're so granule, may be obstructed when you're looking at these. They have a small nucleus that's often eccentric within the cells. That means off to the side versus centric. Here, these ones are from the distal convoluted tubule. (15 to 20 microns in diameter. Now, they are rounder or oval with granular cytoplasm. Dense nucleus, it's usually eccentric. Now, these kind of look more centric, so it's never a great way to determine. This is why I'm not going to bust you on what they are, because these look very similar to those transitional cells. The big difference is going to be, they're going to be a little smaller, but not that much smaller. The big thing is going to be the granular. When they're more granular, that's going to be your indication that it's likely more of a renal. Cells from the collecting duct are 12 to 20 microns. So you're going to see, it's not going to be really easy to distinguish them based on size because they're all very, very similar. Cuboidal or polygonal or columnar in shape, they are never round. So when they're from the collecting duct, they are never round. A large single nucleus occupying 1/2 to 2/3. So it occupies a huge part. The central nucleus is going to occupy a huge part of this cell. We've got relatively smooth cytoplasm, and oftentimes they have this corner or straight edge also. The difference here, so you can see how this kind of looks like a squamous. The difference is going to be the size, because squamouses are a lot bigger. So they'll be a lot smaller. So when we start seeing these diseases, what are we looking at? Or these cells, what are we looking at? Depending on the type of renal cell we're looking at, will kind of guide us towards disease process. We're going to have either an active tubular necrosis, so something's happening to those tubules, they're being destroyed. We can have viral infections that are involving the kidneys. Renal transplant rejection, so not only will we see the lymphocytes, but we'll see some of these renal tubular cells. And then drug and heavy metal intoxication. So people, lead, I think I mentioned it in this course, we're seeing lead poisoning again. We thought we kind of took care of all that in the 70s and 80s, but these old homes, as people are going in and remodeling, they're actually opening up the lead again, and they're getting exposed to lead again. So it's really important to pay attention, if you have an old home and kids in particular, if you see these cells in kids, we're gonna be thinking something's going on with metal poisoning. Increased number of renal tubular cells. You can also see signs with a fever, chemical toxins, any sort of inflammation, infection, or neoplasms, so cancers. So we're looking at renal tubular cells versus squamous epis. So here is a nice squamous epis. Here are some transitional cells. Here are your renal tubular cells. So you can see this is a much bigger nucleus. It's a little more off to the side. These nucleuses are bigger, and you can see these are a lot more granular than these guys. I'm not busting you on those though, right? You can see how hard they're gonna be to differentiate. It's okay. Take notes, have notes in your pocket, try to get them right, but I'm not gonna bust. If you tell me they're one or the other, I'm okay with that. Because unless you're dealing with these all the time, it's gonna be difficult. And when you're in the lab, you're gonna want somebody else looking at it over your shoulder, verify, what am I looking at, right? Especially as you're starting out, there's gonna be a lot to figure out here. Renal tubular fragments, in the collecting ducts, sometimes you're gonna get these fragmented cells, indicate more severe tubular injury, something's going on with that basement membrane. Now to be considered a fragment, at least 3 cells must be sloughed off together with the bordering edge intact. So it's a whole fragment, so a whole piece, it's not just a single cell coming off, it's a fragment, it's multiple cells coming off together. Oftentimes we're going to see this with red blood cells and white blood cells, as well as casts. So this is what it looks like when you get, so you can see these are renal tubular cells, and they're all coming off together. That's never good.
Is that where the storage iron is held in then? Are those cells?
No.
No.
No, these are just the cell line, the lining cells. They're so epithelial cells are like what we have on our skin and our mouths. Everything that's like open to the outside is epithelial cells. And so this is just the lining cells. So they're not gonna hold that kind of stuff. These are just stained with like, probably a supervital. I'm not sure what they stain those with. Oval fat bodies. Oval fat bodies are renal tubular epithelial cells that are engorged with fat, okay? Anytime we see fat in the urine, we're looking at nephrotic syndrome. We'll talk about nephrotic syndrome in a couple lectures, but think nephrotic syndrome, fat. Those two things go hand in hand. I'll keep telling you that over and over. If you have a question on your boards or on my test about fat in the urine, it's nephrotic syndrome. If you have a question about nephrotic syndrome, think fat. So what happens with these is you get this excess permeability of the glomerulus, and so because of that, the fat is going to be absorbed into the cells from the blood into the urine, and they're going to often be seen with other free-floating fat in the urine. That's a lot of F's in a row. Free-floating fat in the urine. So you're never going to call an oval fat body unless there's other free-floating fat, and you want to be super careful because this will be one of those things. If you call fat in the urine, it's going to trigger a whole bunch of stuff because that means they have nephrotic syndrome, and that's bad. Okay? This is called lipiduria when you have fat in the urine. Any sort of lipids in the urine when you have the fat, whether it's in the renal tubular cells or free floating, is lipiduria. So when you're identifying these oval fat bodies, you can use a stain. This is going to be one you're going to want to make sure you get the confirmatory tests on. It might even be a send out. Sternheimer-Malvin stain. When you do the stain, oval fat bodies don't stain, but you get they will appear highly refractile in it. Sudan 3 or oil red O stain. They're going to stain your neutral fats, such as your triglycerides. When you're dealing with polarized light, cholesterol will display this like Maltese cross. You can kind of see it here. Maltese cross is like the fire department logo. When you kind of like look at that, that's what we're looking at. It's a white cross on a black background. Starch displays a similar Maltese cross pattern, but can easily be differentiated by its dimpled appearance with bright field illumination. So just because it's got that Maltese cross does not mean that it has to be fat. It could also be a starch. So here are some free fats and oval fat bodies that are stained with Sudan 3. The fact that it's staining indicates that it's a triglyceride. Large fat-filled oval fat bodies unstained here with the polarized light there. So you can see that nice right there in this picture. You can see that Maltese cross. That's going to tell us what we're looking at. Now, hemosiderin inclusions. 2 to 3 days post a hemolytic episode, so if something happens, you have a hemolytic issue, transfusion reactions in particular. You're likely to start seeing hemosiderin inclusions. You're going to see on wet preps, they're going to be these yellow-brown granules. Sometimes you're going to see them in the cytoplasm of renal tubular epithelials with incast or free-floating. This is probably what you were talking about. Inclusions, the hemosiderin inclusions, Donovan, wasn't it? This is what you were talking about. This is where we're getting with that. I get where you're going now. You were just a couple slides ahead of me. I thought you meant in those sloughs. You're not going to see full sloughs with them, but they'll be in individual cells.
I know, like, when they get weighed down, like, the hemosiderin will go into the urine, so that's, I guess, what, I thought those were the cells that they were in.
Yep, they're in the renal tubular cells sometimes, but they're not in the sheets.
Right.
You were asking about the sheets, right?
Mm-hmm.
Sheets slough off because of toxins and chemicals and other disease processes. You won't necessarily see the sheets with this. I just wasn't going where your brain was there. You were ahead of me there. Sorry about that. I totally have him confused. He's like, I read. This is where we can use a Prussian blue stain to confirm presence. So here is a hemosiderin containing tubular epithelial cell. So mucus threads. Mucus threads are fun. Thread-like structures with low refractive index requiring observation under subdued light. So what happens with these is we see them a lot just as contamination in these urines. Because again, remember I talked about how many hands it takes. I'm going to keep reminding you, the clean catch urine on a woman, always be skeptical of what you're looking at. We see these a lot, oftentimes in female urines. These mucuses are made from uromodulin. Uromodulin is the protein that we talked about that's made in the kidney, it's made in the nephron, it's made in the urinary tract. We'll talk about uromodulin in a couple more slides. Because it's made in the renal tubular epithelium, we always get some mucus just made by the kidneys. Okay? Usually when people are well hydrated and they're urinating a lot, we're not going to see a lot of mucus buildup because of this. There is no clinical significance. However, sometimes larger strands are going to be confused with other things. So here is mucus. Here is mucus. This is a hyaline cast. Here's a hyaline cast right here. So you can see sometimes they can be confused with each other. We'll talk about, when we talk about casts coming up, we'll talk about differences